Alright, well welcome everyone. We're really excited to see some familiar faces back from the last one. And our topic this month is heart health. So like we said, we're doing a JRMCU. It's an educational forum that we'll be hosting every month. Next month will be diabetes on March 27th. If you want to mark that in your calendars right away. I'll remind you again at the end. This month our key speaker will be Dr. Sarah Schatz. She is from Sanford Health. She's a family practice physician. For 20 years?
I've been at Sanford Clinic for 3.5 years.
3.5 years at Sanford. And then we'll also have Emily Chelland, who is our exercise physiologist here at Jamestown Regional Medical Center in the cardiac rehab area. So she will be also going over a few things regarding heart health. So I'd like to start by welcoming Sarah, and we'll just do a presentation, very informal. Again, you're welcome to ask questions at any time throughout the whole presentation, and then at the end we'll also have some question answers. So thank you again for coming.
So you guys, you braved the snow and the slippery roads to be here. That's good. This talk is from the American Heart Association, and it talks a lot about women and heart disease. And if you've been watching the news, you've probably heard about women's health, women and heart disease, because it seems like for a long time we talked a lot about men being the #1 killer of men, and kind of ignoring the fact that women die from heart disease more than any other disease. And so, but at the same time, gentlemen, I don't want you to feel left out, because a lot of the information is the same. It's just that there are a few caveats with women. The Go Red for Women campaign is something through the American Heart Association to promote awareness about heart disease in women. And I've got my little red dress on today. If you ever see those, that's part of the Go Red for Women campaign. And women and Go Red, Go Red for Women and heart disease goes together, and it talks about educating people about heart disease being the #1 killer of women, and causing 1 in 3 out of women who die, 1 in 3 of those deaths would be heart related, which is a lot. And then it also, like I said, is about kind of creating a forum for women to talk about heart disease and learn about it and promote information for each other. So I don't work for the American Heart Association, so I can't tell you all of the things about it, but the website's pretty nice. So this talk is we're gonna go over a few things. What is heart disease? Why is it important? What have we learned? What is a heart attack? And am I at risk? How can I prevent it? And I'm not really going into the Go Red information so much. So heart disease, there's lots of things that fall into that category. Coronary heart disease basically means that the coronary arteries, you've had a heart attack or you've had a blockage, and maybe you have a stent or you've had bypass surgery, you have coronary arteries, heart disease. High blood pressure, heart failure, valvular disease, rheumatic heart disease, and then there are diseases of the pulmonary circulation. But mostly what we're talking about is heart attack today. And then, so again with the Go Red, we're talking about women. I think how many of you knew that heart disease was a leading cause of death in women? Most of us. It's been really out there. If you watch the news at all, it's really been something they've been talking about. That, and now anorexia in boys and all kinds of crazy things on the it's too bad, but getting off topic. So basically the cardiovascular disease kills about 421,000 women a year, and that's the 1 in 3 female deaths is from cardiovascular disease. 64% of women who die suddenly from coronary heart disease have no symptoms, no previous symptoms. They never had any chest pain or shortness of breath or anything like that. It just can happen suddenly. And then heart disease may be prevented if we take and make the right choices, and in our activities and what we eat and how we manage our stress and all kinds of things. So what is a heart attack? I'm sure you've seen it, we've all seen it in the movies. You know, it's the, oh, I've got pain in my chest and my left arm, and then I'm falling, and then they're rushing me to the hospital, or I might be dead, just right then. That's kind of the movie version. That's not the real life version though, really. Because, and this is where women are a little bit different than men. A lot of times there's chest pain, pressure. Not like I'm getting stabbed in the chest with a knife or something. It's like heavy, like you've got an elephant on your chest. And then you get short of breath. You might get kind of clammy and cold, sweaty. You might get nauseated, feel lightheaded. If you get these symptoms, you obviously want to call 911 or have somebody else call 911 for you. Now, if any of you have had a heart attack and you didn't have any of these symptoms, that's not unheard of, because like we said, there are different symptoms for women sometimes than men. And those symptoms a lot of times have to do with more kind of the stomach. My stomach hurts, I'm nauseated, and I feel really icky all of a sudden. That's not usually a symptom in men, but more in women when they're having a heart attack or problems with blockages in the arteries in the heart. So, am I at risk for heart disease? If you have any of these risk factors, then you kind of are at risk. There's varying degrees of risk. We can categorize you into a low risk, medium risk, high risk. But really, there's only a few things that you can control. The things you can't control is your age, your hereditary, your family history. And then African American people are more likely to have heart disease than some other groups. The things you can control, though, are your cholesterol and your blood pressure. If you're physically inactive, that's something you can change. If you're overweight or obese. And then type 2 diabetes. And the big one, it's at the bottom, but it should be like in big, big, big red letters, smoking. So I was going to ask if anybody smoked, but then I thought that would be mean, because we'd be singling out the smoker and they would feel bad, which they should, but I don't want them to feel bad today about themselves. But really, when we talk about heart disease, smoking is so bad for you. Really, really, and that's probably the biggest thing that we like to have people work on. So if you go to your doctor and you get your annual exam, they're probably going to check your cholesterol once in a while. And you may or may not know your cholesterol today, and that's okay. I don't remember what mine is, but when you get your letter from your doctor, or they call you, or they go over your results, usually you're going to have 4 numbers that you're going to hear about. The total cholesterol number is important, and these are the ranges. Usually it's best if it's under 200. But that doesn't really tell us everything. A lot of times it seems like in our part of the world there are a lot of women who have really good cholesterol, which is awesome. So if you have your HDL, which is the good cholesterol, I was trying to think of a way to help people remember HDL equals good. I was like, good H, good heart, you know, whatever. It doesn't matter. It'll always say good cholesterol next to it, so you don't have to remember that. But if your good cholesterol is greater than 50 for women and 40 for men, that's great. We like that. If your good cholesterol is 80, then I am so excited to be your doctor, because I love it. I love it when the HDL is good. That protects your heart. That helps protect you from having plaques building up in your arteries. It's nice to have a good HDL, and that's a lot of times genetic, but it's also, you can control your HDL by being physically active and eating a healthy diet. So that's important. That's a big important part of this. Bad cholesterol, the LDL cholesterol, usually if you don't have heart disease, then, you know, say you've got high blood pressure, you're at risk for heart disease, and your bad cholesterol is over 130, then I'm going to want to talk to you about starting medication to control that, because you're probably at risk for heart disease, especially if you have high blood pressure. But if you have lots of other symptoms or lots of other risks, then we really want to control it. Like if you have diabetes, or if you've ever had a heart attack, then we need it less than 100. And some people, the recommendation is down to 70 or 80. So the bad cholesterol is really important. Now, most of the studies that have been done about heart disease have really focused on men. They haven't really teased out how women are different and how the treatment for women is different than for men. One thing they found is that for men, keeping your LDL cholesterol really low is more beneficial than having a really high HDL. But for women, keeping your HDL high is more important than your LDL, believe it or not. So that's one thing, which means that as there's more research done and more research into women's health, there probably will be a difference in how we treat. You know, different medication targeting the cholesterol differently, or targeting, and this may have to do with how we treat lots of other things too, but with regard to heart disease, that's kind of an interesting caveat. I find it interesting. You maybe don't. I don't. The other thing you'll see on your cholesterol report is your triglycerides, and we don't want those to be high either, because that increases your risk for heart disease as well. And normally you would like them under 150. There are some folks out there who have a hereditary hypertriglyceridemia, and their triglycerides are like 800. Whew, really high. But those folks need to be on medication. And I think from my point of view, the important thing is that if you do have high triglycerides or high cholesterol, and you get started on medication, and then you're like, you know what, I don't really like the medication, I don't like the way I feel, it's making me achy, or it's making whatever's going on, please let your doctor know, so that if that medication doesn't work for you, there may be another one that does. And this is one of those controllable risk factors for heart disease. I want to help control your risks, and so please let me know if that happens. Blood pressure. I mean, this is all sounding familiar, right? We're talking about your cholesterol, your blood pressure, your weight, your smoking. I mean, these ideas haven't changed any, but if you have high blood pressure, it's really important to have that controlled if you've had a heart attack. If you have never had a heart attack and your blood pressure is kind of in the pre-hypertension range, it's still really important to control it so that we can help prevent heart disease, lower your risk for heart disease. So again, that kind of goes along with, you know, if you're on blood pressure medication, it makes you feel bad, talk to your doctor and let them know so that that can be adjusted and that we can control your blood pressure without. Now the other part of this is that a lot of people, I just saw somebody today who has been exercising and has lost probably 8 pounds or something, and blood pressure has come down. Just with exercise. Not really even trying to lose weight, but has benefited by exercising, and so has lost a few pounds, and their blood pressure has come down on its own. They weren't on medication, and I'm not going to start them on medication just yet, because maybe they won't need it because of their exercise. Of course, smoking makes your blood pressure go up too. So exercise, I was just mentioning it. A lot of people are inactive, and again, this is about women, and this kind of breaks it down into different ethnic groups. But for white women, you know, more than half of white women are inactive, and all healthy adults ages 18 to 65 should be getting at least 150 minutes of moderate intensity or 75 minutes of vigorous exercise per week, or a combination of the two, which is not that much. I mean, if you break it down, it's hard to exercise. It's sure not easy to find time to do it. I know, I have a hard time making the time. because if I don't get up in the morning and go do it, it doesn't happen. Or, you know, it maybe happens, but not very begrudgingly either way. But the point is that 150 minutes of moderate intensity exercise may be a nice brisk walk, 30 minutes a day, every day. So, or you can exercise longer or less. But the truth is that, and you're probably going to hear it on the TV now, you've seen the NFL is advertising for kids to get out and exercise 60 minutes a day, and it's just going to start getting jammed down our throats. So if we're already exercising, we're like, fine, we're there, don't worry, we're good. But if we're not, every time we hear it, it's kind of like, ugh, I know. You know what I mean? Okay. So then another risk factor, obesity and overweight. Excess weight strains your heart, raises your blood pressure and cholesterol, and can lead to diabetes. And then the number of women that are overweight and obese and have diabetes has gone up, certainly. And sometimes this, I think that this is just as important to remember when we talk about heart disease as it is when we talk about diabetes. I mean, usually when you go see your doctor for your checkup, they're like, you know, you're kind of overweight, you don't want to get diabetes. Well, actually, yeah, you don't want to get diabetes, but you don't want to have a heart attack, like next year, or, 20 years from now. So we do need to work on that. And truly think of obesity and being overweight as more of a chronic disease than just a you failed and you're fat. I'm overweight, I'm working on it, And that's where I tell my patients the same thing. You're overweight, you gotta work on it. And if you're exercising, then you're doing a lot of what you need to do. But eating right, and today you have the healthy lunch, very manageable number of calories in the lunch I saw. Managing what we eat is huge. But I kind of get off on a tangent sometimes, so I'll get back to the screen here. So diabetes. Diabetes is a huge topic that I'm not going to spend a lot of time on because that's a whole 3-hour talk on its own. But diabetes does increase your risk for heart disease significantly. You're 2 to 4 times more likely to develop heart disease than somebody who doesn't have diabetes, so that's significant. And then also the complications of diabetes, there's many, of course. So that's that other big risk on our list of controllable risk factors, is to try to prevent or avoid getting diabetes. And then the big one, the smoking risk, another controllable risk factor. I love this slide because people don't think about, well, they're like, smoking, what's the big difference? Who cares? Cancer, who cares? Whatever. That's how my dad was. He quit smoking cold turkey. I was amazed because he found he was short of breath when he'd go for his run. That was the only thing that made him quit smoking. He was uncomfortable running. I'm like, well, what about all the complaining, Dad? We've all been complaining for years. But truly, within 1 to 2 years of quitting, your risk for heart disease goes down significantly. And I've got some other things here. Within 24 hours of quitting, your blood pressure and your pulse rate drop. Within 2 to 12 weeks, circulation improves and lung function improves. Within a year, the excess risk of coronary heart disease is half of what it was when you were smoking. And then 10 years and on, your risk of lung cancer death is half of that of a smoker. So that's those are important numbers to think about when and maybe you don't smoke, but maybe you know somebody who does. That's usually the case. You guys are here because you want to take care of your health. And so you maybe have a friend or a family member who does smoke and you want to help them quit. There's lots of information to help people quit smoking. It's not easy, just like losing weight isn't easy and exercise isn't easy. None of it's easy, but it's essential. And probably the biggest thing about the talk that I like to highlight is that we really need to help people quit smoking. So what can I do to prevent heart disease? Eat a healthy diet, low in saturated fat, trans fat, and cholesterol and sodium. Keep your weight under control. Control your blood pressure and cholesterol. Manage your blood sugars if you do have diabetes. Get regular checkups with your doctor. And then talk about prevention with your doctor and medicines that might be right for you. If you are worried about heart disease and you have a family history of it and you want to do everything you can, then when you see your doctor, bring that up. And then, of course, don't smoke, avoid tobacco smoke. Okay, let's see if we can get this to work. This is not that exciting, by the way. I was hoping to find like the perfect med movie showing you the coolest thing about the heart, and I didn't. Because I can't do any YouTubing at my clinic. Okay, but if you've ever wondered exactly what's going on in your heart when you have a heart attack, basically, let's see here. So the heart muscle is supplied by arteries, and those coronary arteries have, normally you have a healthy lining to the artery. Does this show up?
Yep.
You know I'm doing that?
Yep.
Okay. And then everybody gets plaque. Everybody's got some plaque in their arteries. And that's kind of what this is. So you can see how that's not as nice and open, but almost everybody has some of this fatty lining in their arteries. Then if we have really high cholesterol and we're not exercising and controlling our blood pressure, we're smoking, then we can have more of this going on. And this kind of a plaque can rupture. And then when it ruptures, you get blood. The blood has all kinds of factors in it that will start to form a clot. And that clot hangs out there, and then it kind of grows on itself. And before you know it, it has plugged up the artery. So that was that. That's the end of the... So, yeah, underwhelming. What are you going to do? I couldn't find a really good one.
There's a clicker there if you want to use that too.
Oh, wow, okay. So, okay. So just because I didn't really put a slide in, if you go to the emergency room because you are, say you're a woman and you're having discomfort and you're, kind of like for your back, and you don't feel good, you go in, they're going to hook you up to the EKG, they're going to see what your heart rhythm looks like, and they're going to probably do some lab work on you, they might do other tests. A lot of times the EKG tells us a lot, and then the lab work is the other big part, because if your heart is being damaged, it releases enzymes, and we can measure those, and that's troponin is what we usually measure. And if your troponin is up, then there's something usually not right. Occasionally it can be falsely elevated, but that's not, it's a very sensitive test. If you're having a heart attack, a lot of times we want to get you to where we can open that up. Open that plugged artery up as quickly as we can, and so sometimes you'll get some thrombolytics, some clot buster, and then we ship you to Fargo where the cardiologist can go ahead and take you to the cath lab and then put a stent in that artery. Sometimes we don't do that though. So the management of a heart attack is different depending on what kind of heart attack you're having and how bad it is and the state of your general health. And sometimes we manage them just medically. You may have had the heart attack, you're stable, and then we're just controlling the other things like your blood pressure and then putting you on aspirin and some other things, depending. So everybody's a little bit different. If you're having symptoms once in a while when you go up a flight of stairs and you feel kind of like tightness in your chest, you don't like it, and it's something new to you, then you should see your doctor. They may want to do a stress test, put you on the treadmill, make you walk, see what your heart does when you have to exert yourself. And then there's also an echocardiogram test that we use to look for for blockages in your arteries. So there's a couple of different ways to look for that heart disease. And then once, say you have a heart attack, hopefully not, because you've been managing all your controllable risk factors, but say you do, then my life after my MI is basically controlling your cholesterol, keeping that really low, the bad cholesterol really low, and then controlling your blood pressure really well. And then the cardiac rehab will start. And of course you won't be smoking anymore. Hopefully if you had been, you won't be. And then the other question is, well, I had a heart attack. How do I avoid having another heart attack? Because people sometimes have many heart attacks. And from my perspective, the biggest thing is to number one, stay on your medication. Number two, stay on your medication. And if you've had a stent placed, then you really need to stay on. They will start you on a medication called Plavix usually, and they put you on aspirin as well. And you have to stay on that for at least a year, usually. And if you stop it, then the risk of having that stent clot up goes way up. So it's really important to stay on that medication, or talk to your doctor if you're having problems with it. And then, of course, controlling your blood pressure, doing your cardiac rehab or exercising, and then no smoking. So really, if you had to take home any points, I think you would be able to list the same ones I've listed already about the controllable risk factors with your blood pressure, not smoking, exercising, controlling your weight, taking care of your sugars if you have diabetes. What did I forget? I'm sure I forgot one. Cholesterol. And cholesterol. Good job. That's great. All right, so this was, this is more about the Go Red. Like I said, I don't really have a lot of information myself to give you about this, but over on our little table here, there's a couple of handouts from the American Heart Association. And if you like to be on the internet, there's some links to use to get online and learn about some of the things that you could be doing in your life to control your risk for heart disease, or if you just want to learn more about heart disease and lots of other things too, that's on there. And then I'm going to turn it over to you. Oh wait, we'll do questions when we're all done with our PowerPoint, if that's okay. She's got one, but.
Don't forget.
I don't know that lot.
Don't forget it, yeah.
Heart attacks are caused by blood pressure low. I think what the doctor should do when you go for a physical, it should be mandatory, to put that cuff on your ankle and your wrist to find out the blood flow in your legs. Now,
You're right.
mine is about 75%. But she said if your calves start hurting you back when you're walking or exercising, then we'll do something about it. It's too late then.
Yeah. You know, that's a good point, and that's more talking about the peripheral vascular disease, that if you have achy legs when you're walking around, you need to have that evaluated.
My son-in-law was 55. In January, he went up to the hospital in Fargo. He had pains in his shoulders for a while. And actually, when he got into that hospital, he was practically dead. He had a massive heart attack. He had 3 arteries plugged, completely plugged. They worked on him for 4 days, 2 heart pumps going, and all his organs broke down. He couldn't breathe on his own, so they couldn't do bypass. So he passed away on a Sunday, 55 years old. Now that wasn't called for. And he'd been going to doctors, but they didn't check that.
Oh, okay.
So I sometimes think it's the fault of the doctors.
Mm-hmm.
I know cholesterol's got a lot to do with it, but that should be checked, I think, mandatory.
Mm-hmm. Yeah, I think you're right. Definitely need to ask if you have questions and you feel like your doctor's not addressing it. It's you have every right to ask about it and say, I'm worried about this. Maybe we need to check it. Okay? Go ahead.
All right. Hello, I'm Emily. I am the coordinator for cardiac rehab. I'm a clinical exercise physiologist. There's also a registered nurse in cardiac rehab. So what is cardiac rehab? It's not just exercising. There's a lot more that goes into it. But the goal and the aim for cardiac rehab is to help those who have had heart disease and a heart attack to recover better, to recover faster, and to reduce the risk factors that they're going to have a second heart attack or have a second heart procedure. And also improve the quality of life for those individuals. Each session does involve exercise. We work our patients up to, sometimes you can only start out at about 6 minutes or so, but we'll progress you to 40 minutes. And then we also increase the rate at which you're exercising or your intensity of exercise. We also provide education on each of the topics we've talked about today, as well as exercise at home and the benefits of exercise. And we also go into exactly what happened in your heart attack. We'll map out where your blockage was in your coronary artery. We'll show you the size of the stent that was put in. Or if you had a bypass, we'll show you where those vessels were bypassed to on your heart. And then for the goals, these are goals for each patient. We help them set both short and long-term goals, and that these all lead towards a healthy lifestyle. These include exercising. We start out 3 times a week, and we encourage everyone to exercise most days out of the week for at least 30 minutes. That is what's recommended by American Heart Association and American College of Sports Medicine. We do currently have. So we check diabetes, or for those who are diabetic, we check the blood sugar every time that you're exercising, before and after. We check your blood pressure before and after exercise and while you're exercising. And then we help with cholesterol management. We don't check your cholesterol, but we do ask your doctor what it is, and if you get tested during rehab and it's better, we do just help you keep track. As well as talking about appropriate eating and weight management, and of course smoking cessation is a huge factor. There are some who having the heart attack is a wake-up call and they immediately can just stop smoking, but there's many who that isn't a big enough wake-up call and they need extra help. I have 2 facts here. Outpatient cardiac rehab demonstrates 25% reduction in long-term all-cause and cardiovascular disease mortality rates. That means those who've had a heart attack and go through cardiac rehab have a 25% reduction that they're going to die from a second cardiovascular event. There's also a 37% reduction in sudden death among post-heart attack patients participating in a comprehensive cardiac rehab program. Who is involved? Who's involved? There's me as an exercise physiologist, a registered nurse. Our dietitian is involved. Each patient has 1 session with our dietitian, and if they need more, we can set that up from there. And we also keep in contact with your primary physician and your cardiologist. Depending on your insurance, we're required to update them periodically with how your progress is going. If anything should come up during the session or in between sessions that you tell us about, we'll contact your doctor. If it seems like your medications are a little off and they need to be adjusted, we can call your doctor for you and they can set up and meet with you, or just call their pharmacy and get everything changed for you. As for a comprehensive approach, we utilize a team approach to cover all the bases that have led to your heart disease. We emphasize making positive lifestyle changes in your diet, exercise, and smoking cessations to better manage your disease. And then our approach is tailored to each individual depending on what it is that they need. Different phases of cardiac rehab. There are 3. Phase 1 is inpatient. So if you have a heart attack and you're in the hospital for a few days, you will see someone from cardiac rehab come up and speak to you. Sometimes it's just a little education. Sometimes they get you up and walk you down the hall. It all depends on what you had done and where you're at in your recovery. As for phase 2, that's what we have here at JRMC. That's what I do. It is an outpatient cardiac rehab, and it's in a specialized facility like we have here. And then there's phase 3, which is also outpatient, and that's a maintenance program. For us, phase 3 is at the Wellness Center, so we recommend people to go down there because it's a supervised fitness facility. So you still have someone who can take your blood pressure, check your oxygen saturation, your heart rate, You won't be monitored like you are in phase 2, but there is someone there to help you should you need something. So who's eligible for cardiac rehab? Those who have had a heart attack, bypass, PCI, angioplasty or stent, and then heart transplant or stable angina. Angina is not just the chest pain, but it's the pain that's sometimes in women, the nausea, in between the shoulder blades and the neck, the jaw. Sometimes it presides as a headache. And in order to begin, you need to have a referral from your physician, and it needs to be for a diagnosis that is covered by insurance. And after discharge, I kind of mentioned with phase 3, it's encouraged that you continue all the great changes you've made and the progress that you've made through phase 2 by continuing on and making exercise an important part of each day. And you do that with phase 3 or at home on your own, which is why we do a lot of education on home exercise, and we'll send you home with a home exercise manual. Any questions on cardiac rehab? No? Okay. Any questions for Dr. Schatz?
I think if you go to the next slide, I'll just there it is.
Thanks, Sam.
You're welcome.
I have a question about aspirin. You hear about patients being given aspirin when they come to the hospital, and there's a lot of discussion about taking aspirin daily. Can you tell us a little bit about that and what's appropriate?
Right now, the recommendation is for men aged 45 to 79 to take an aspirin a day, a baby aspirin a day, if they're at risk for heart disease and they don't have other things that, and this is where you need to talk to your doctor and make sure that you don't have other risks that could, you haven't had a bleeding ulcer or something else. And sometimes your medication can be a problem. But right now, the recommendation for men is age 45 to 79, and for women is 55 to 79. The reason it's the 10-year gap is women tend to have their heart attack a little bit older, usually in their 60s, 70s, as opposed to men sometimes having it years younger. But either way, I would talk to your doctor before you start, just so that you can be sure you're safe to be on aspirin. Yep.
What about taking aspirin with dabigatran?
Now, dabigatran, it depends. Dabigatran is one of those new anticoagulant medications, and it depends on your risk. And again, it will depend on the other medical problems that you have and whether or not you've had risk for bleeding. Because if you take aspirin and dabigatran, you will have a greater risk for bleeding potentially. And but it's all about weighing the risks and the benefits. So if you need it and your doctor recommends it, then you should. But typically, and dabigatran is kind of like Coumadin. So for those who don't know what dabigatran is, it's kind of like Coumadin.
It's a lot better than Coumadin.
It's better than Coumadin in some respects. Yeah.
They don't use it for rat poison. For that one.
Well, dabigatran, you don't have to get your blood measured like you do with the Coumadin, which is good. But there are some caveats with dabigatran with regard to bleeding too. So, unfortunately, nothing's perfect.
What about Plavix, aspirin, and Coumadin?
There are people who are on all of that.
Why?
And that is beyond my specialty. I don't start you on all of those. Sometimes cardiology will have you on all of that. Like if you had a blood clot. If you were on Plavix because you had a stent put in, and then for some weird reason ended up with a blood clot in your leg, you would have to be on Coumadin for 6 months in addition to your Plavix. And you'd probably be on the aspirin as well. So yeah, not very often does that happen. But that is a very special situation.
What is it about stents that need Plavix but not bypass?
The difference is that the stent is it's a metal device, and some of them are more likely to have platelets aggregate on them than others. There's drug-eluting and non-drug-eluting, and that's, but the studies have shown that if you don't take your Plavix and that metal stent is in there, you potentially are going to clot it off. Now, when you have a bypass graft, you're taking one of your vessels, and they're basically sewing it up to the heart, not some foreign object. And so you're not going to clot your own vessels like you would a foreign object. Did you have a question?
My oldest son is on Coumadin for the last 3-4 years. He had Europart, he had blood clots went up into his lung, and so they finally put a mesh in his groin so it won't go up, but it'll go down to his legs. So,
well, what the mesh will do is people sometimes are more prone to get blood clots. Usually they come from the legs. Then they travel up and end up in the lungs. So they'll put a mesh in, they'll go through the groin, they put the mesh, it actually sits in the vena cava, which is the big vein in your tummy. And that way, blood coming back up, it'll filter out any clots so that nothing will get pumped into the lungs. Because that's where the clots can kill you. You know, clot in your leg doesn't kill you. A big clot in your lungs can kill you. So it'll prevent that. And that doesn't happen, not everybody gets that. That's another specific situation where maybe you've had many clots, or maybe you don't tolerate the anti-coagulation medication very well. And so that's why they put that in. So, did you have another one?
I did. I was another question about aspirin. So
Sure.
if you feel like you're having a heart attack, you know, are you supposed to? You hear you're supposed to take aspirin right away. Is that right?
Yes, you can take 2 regular strength aspirin right away at home if you are having that crushing chest pain. But make sure they know that when you get here, so they don't overdo it and give you a bunch more. But yes, you can. Yeah, that's like Bayer. That was their big Bayer Saves Lives. The ad campaign for Bayer aspirin. Or they used to have a campaign, I guess.
And 2.
Yeah. Yeah, and chewable aspirin is good too because you kind of start to get it going faster. You absorb some of that right away into in your mouth. You start to absorb it, and that sometimes even is better. I think that in the ER they usually give you the chewables.
Yes, I always heard that that's what it should be. That it should be
Chewables. Yeah.
Not the interior.
Yeah. Yeah. The enteric coateds, you know, are coated so that they don't irritate your stomach so much, but they don't get digested, absorbed as quickly. And you want it quickly, so the chewable aspirin's the way to go. Any other questions?
Do you have an echocardiogram machine here at this hospital?
Yes. There is.
Yes, we do, and then they do the the technologists here are trained to do them, and then because we don't have a cardiologist here in Jamestown, the reports are sent to the cardiologist, and we just have, in St. Cloud, they have a big cardiac center there, and they're read right away, and then the results come back and go to your physician that ordered them. Stuff, so.
Are we doing them every day now?
You know, we have there's a lot of good training that goes in. You want to make sure that you're good trained, and I don't think quite half of the staff are trained yet. So at first, when we were first doing it, it was very specific days. Now I think it's according to, they'll kind of, if somebody's working that does one and there's an order, then they'll kind of do it. So sometimes it still varies a lot, but I think they do them a lot more now than they used to. So, yeah.
Did you have any other questions?
Are you taking blood pressures today?
Yeah.
Yes, your blood pressure will be tested.
Yep, you're very welcome to stay and get your blood pressure if you haven't yet.
Definitely.
Why are they so slow at actually coming up with new things for women?
You know,
Understanding the woman that practices.
I don't know. I think that the difference in there's I don't know. Why they're slow? I think it's just because of not knowing that there was such a difference in how men and women are the respond to medication, metabolize medication, how men and women present with symptoms being different. I'm not sure why, but I know that it's out there now and that's being studied, definitely, with regard to heart disease and I'm sure to other things too. I haven't seen anything specifically, you know, but there's definitely a difference between men, women, black, white, you know, with all of the different genetic components that are involved. There's definitely a difference in how you metabolize medicine and how I metabolize it, you know, and that's something that's being studied with now that the Human Genome Project, how they've mapped all of the genes, so now there's new stuff being researched. I don't know any details.
Is it a waste of money taking salmon oil and flaxseed oil and all this stuff supposed to be good for the heart?
It's not a waste of money. Not a waste of money. If you take omega-3 fatty acids, those do help reduce your cholesterol and can be heart healthy oils, you know. Better to use, like, and I'm not trying to promote anything, but you know, if you're at the grocery store and you want to buy, you know, margarine or butter and you're like, well, the cholesterol is high in butter, but it tastes so good, but I don't want it. You know, there are margarines now that have the omega-3 fatty oils in them. You know, like the Smart Balance, I think is. And yeah, so it is not a waste of money to take those supplements to bring your cholesterol down and improve your cholesterol numbers.
What do you recommend for other daily vitamins or?
Well, it depends. I guess for most people, just a regular multivitamin. But you really should be getting. And I'm not a nutritionist, and they would probably have all kinds of other answers for you. But if you are eating 3 cups of vegetables a day, and eating fruits, and eating a wide, you know, you're eating the right amount of carbs and meats and everything, then you're going to get. You probably don't need to take a multivitamin at all. But as we get older and our cholesterol does start to go up, that's when you start thinking about adding the omega-3 fatty acids. And then some people need to be on B vitamins and other vitamins. You gotta be careful though, because if you're taking a bunch of the wrong kind of vitamin, it can be harmful to you. You know, I was just looking at it's not recommended that you should not use antioxidant like vitamin supplements like vitamin E, vitamin C, beta carotene. That should not be used for prevention of heart disease. So if you're taking high doses of those, you should not do that. You need to talk to your doctor. It's just not been supported by evidence. Folic acid is good for you, but taking a lot of extra folic acid or B6 and B12 is not used for the prevention of heart disease. It is used if you have a deficiency, then you need to take them. And they've actually shown that some vitamins can be kind of pro-cancer, and so you need to be careful on what you're taking and talk to your doctor about it. Did you have something in particular you're thinking about?
Nope.
Since we're talking about women, probably calcium.
Definitely calcium. Vitamin D calcium and vitamin D together. You need 1,200 milligrams of calcium a day, and usually that's in 2 doses. Your stomach won't absorb all of that at once, so use 600 and 600. And then the recommendation for healthy adults in our region is vitamin D of 2,000 international units a day. Some people need more. And that's because we just don't get as much the rays of sunlight that you get closer to the equator. So you don't get to make as much vitamin D with the sunlight as those folks do.
Would it make any difference if you took your medicine with a meal, like your calcium?
Calcium, you know what, and that's a great question because calcium in particular and other vitamins and minerals can block the absorption of some of your medications. It's fine to take your multivitamins with your meals. That's fine. But if you're taking thyroid medication and some of your heart medications, you may want to double check the bottle or with your pharmacist to make sure you're not taking something with your calcium. It's going to block, the calcium will block the absorption of like your thyroid medication. So you do need to be aware of that. If you can't just take them all at one time. Although that's easier. Yeah.
You mentioned vitamins, or do you have a list that you shouldn't?
I
do?
don't have a list, no.
Where would one go look for a list?
Of vitamins that cause cancer?
No, well,
I don't think you'll find that list.
no.
No, I don't think
You
we
said
find
if you
that
have-
list.
If you're pre-cancer or have cancer, there's some vitamins.
You know, I think if you went, like the American Heart Association website, do you get online? Do you use a computer much?
Oh, I get my wife on
You
that.
get your wife online, okay, that's good. I think there's Nutrition Center, there's a couple of websites on here that probably would give you some more information about that. And
Which one?
vitamin E in particular is the one that I'm thinking about that you don't want to take too much of. Don't overdose on the vitamin E, that's just not good for you. So, perfect, you don't need to worry about that. You don't need to take it.
When I was 7 years old and my father got his first heart attack, then my mom and dad flew to Ontario where there was a shoot, it's called the Shoot Institute. And here at that time, they were promoting vitamin E and put him on a lot. And I know he lived many years, but he had 5 massive heart attacks in the meantime.
Yeah.
Right.
I can't,
So it's interesting how
Yeah.
they change and what they prove and.
right now, almost all of the research that's done is tried to be evidence-based recommendations. So they do research and then we try to make recommendations based on the good, solid, quality evidence as opposed to, professional like opinions and I think it's good for you, why don't you take it? That's not necessarily how they used to do it, but without good evidence-based information, there've been things that we've done differently in the past that now aren't supported by the research. So I don't know. They use, vitamin E for your eyes. You need enough vitamin E for your vision. But if you eat a normal diet, you don't need to worry about taking that.
What vitamin is it that if you were a smoker, that you shouldn't, like, is it vitamin E or is it A that you should watch? Or
And vitamin A is the other one. Yep. Oh, and I feel bad because I'm telling you this, but I don't remember specifics off the top of my head about the research. So
But if you smoke, you want more vitamin C.
Did
If
you
you're
say-
a smoker.
You said vitamin A, you don't take it?
yeah, you don't want to take too much vitamin A or E. But I did not come here prepared to talk to you guys about vitamins, so I've not done a lot of reading on them recently.
You're doing all right.
I can Google something. No, I'm just kidding.
We also have our dietitian in the back too, so if we have any
Yeah, that's who
food questions.
You should correct me if I'm wrong, by the way.
I just chimed in, vitamin C if you're a smoker. On increased vitamin C. That's my 2 cents. You're doing a good job.
Oh,
You're doing a
thanks.
good job.
Thank you. Well, any other questions?
We have time for about one more.
You feel confident that you can go forth and do everything you need
Yeah.
to do? Yes, sir.
Getting back to the aspirin thing, you said 45 to 79. What about after 79?
Yeah.
After 79, that's a great question. That's again the time where you need to have that discussion with your doctor to look at your risk factors. Most people, I would say, they should continue on their aspirin. But some folks, 79 and older, are at a higher risk for bleeding. And those folks probably, you need to decide, do I want to take the risk of having bleeding? Because the aspirin can make you bleed. Or do I really need it to prevent X, Y, or Z? So you need to talk to your doctor to make sure that you are taking it appropriately. But thank you, that's a good question. I didn't mean to exclude that group. But for stroke prevention, most of the time we say, yeah, aspirin does help prevent strokes. You know, and that's the other part. We talked a lot about heart disease. We didn't really talk about strokes today. But strokes are like heart attacks. Usually there's a vessel that can get clogged, and that's how you end up with a stroke. The aspirin helps prevent that from happening.
When should a person start taking aspirin?
If you're, well, like I said, you should talk it over with your doctor. But for men, it's age 45, and women, it's 55.
And that could be a regular aspirin, like 325.
Just the baby aspirin. A baby, 81 milligram aspirin is fine. The increased dose of aspirin increases your risk for bleeding. So, and there's no added benefit for prevention of heart attack or stroke with the higher dose. So that's where the 81 milligrams is the best dose. Unless your cardiologist tells you different, then you need more.
What about aspirin versus dabigatran?
Well, aspirin does not do what dabigatran does. It's not enough of an anticoagulant. You know, it's not going to.
In other words, dabigatran does a better job.
Yeah. And they work a little bit differently.
Should
In the clotting cascade, they're different.
It should do a better job. It's about 100 times more expensive.
It is expensive. Yeah.
Is there a generic for Plavix yet?
No, not yet. Soon, I would think. I can't remember how many years Plavix has been out.
Plavix?
Yeah, it's been out for long enough that a generic should be coming.
I know I took it about 5.
Well, we'd like to thank you again all for coming. It's really exciting. We're really excited to be hosting a community education, and it's free, so if you'd like to share it. Again, March 27th, we will be talking about diabetes. And again, it'll be noon to 1 in the same room here, and we'll also offer another free lunch. Not sure if it's heart healthy yet. There may be a cookie, there may not be. Cookie or fruit. It's a toss-up. We'll see. So, but we'd like to thank Sarah for coming, or Dr. Schatz, sorry. She did a great job. If you guys have further questions, you can get in contact with the hospital here and ask for Sam in marketing, and I can refer you either to Dr. Schatz to get further questions, or you can make an appointment with her and talk it through. Otherwise, we have cardiac rehab here. We can get you set up with an appointment there, and also our dietitian. So if you have any questions on setting up a healthy meal plan or questions about anything health related, we can get you the answers. So thank you again. Again, if you haven't RSVP'd for this one, I'm looking forward. Again, we'll probably ask for an RSVP just so we know how many meals to make and stuff. So just a call or an email letting us know that you'll be here is great. So helping with the numbers and our seating. So thank you. Drive safe. It's starting to snow.